So I'm going to introduce myself. There's going to be a lot of basic science here somewhat, and that's probably real good after a good lunch. Everybody's going to be a little on the sleepy side, so y'all will go right through it. This particular lecture is going to kind of fall right in line with what Craig was talking about. It's going to be talking about drug delivery. Obviously, the drug delivery at the cellular level is very important, and it's becoming more important as far as restenosis. And what I'd like to talk today about is the occlusion perfusion catheter. Now, we know that regardless of what we do to a lot of these vessels, you're going to have restenosis. Trying to maintain patency is very difficult. And we do know that with neointimal hyperplasia, that the only way to treat it is going to be at the cellular level. We've done everything. We've cut plaque out. We've ballooned it. We've stented it. We've done all this stuff, and we still have been unable to overcome restenosis, which is clearly our nemesis. All right, we've got drug-eluting balloons, which clearly we have a pretty good data on right now. And there are some limitations to that, okay? The limitations is that you got a single device and a single drug or a single agent which is tied to this. There's a limited amount of agent which can be incorporated. And you know, if you put a stent that's got drug on it, only about, as far as surface area goes, only 18% of the stent is actually in contact with the vessel wall. So what happens to the drug that's there? All right, and so you do burn bridges. And the most important thing is the cost. You go in and have a 300 length SFA that you treated, and you sit and use 6 drug balloons to just cover that area. That runs into a little bit of money, and you'll get called to the principal's office pretty fast. Now, how do you overcome the limitations? That's the first thing you have to ask yourself. How can we overcome this? And what we do is you got to have some form of delivery system that you can have that can be very variable, if you may, okay? And you don't want to be limited to one drug. We may end up having to find out that you can use a mixture of drugs, a cytal drug and a static drug both, and that may be the optimal thing. So we're not really sure yet, and we're still in the infancy phase of learning about all this. You want to be able to deliver the agent. You don't want to just go from the intima. You want to go into the media, and if you can get all the way out to the adventitia, that would probably be even better. And it needs to be able to use in conjunction with other things. This particular device here is the occlusion perfusion balloon, and I'm actually going to skip several slides by explaining a lot of this stuff here. And let's see here. My slides did not go through the way I wanted them to, but that very first picture that you saw, here we go, is Dr. Teeslink. And Dr. Teeslink, actually, if you remember, was the fellow that was in the middle with the pink tie on. He's actually invented this particular catheter, and I have to give him most of the credit for that, or all the credit actually for doing it, and we're actually trying to help do some of the research. Let me go back to this catheter. Now, what this catheter does, all right, what you do is you have occlusion. You have 2 occlusion balloons here. They create a chamber. There is a sensor here. There's a sensor on the distal part that senses pressure. You have an egress and an ingress port. And what you do is you occlude, you flush the chamber, and then after you flush the chamber, you ingress the treatment drug. Oh, there you go. You ingress the treatment drug as the blood egresses. And once you flush a chamber and you fill this full of drug, the middle balloon actually is not a treatment balloon. That's an atraumatic balloon. It opens up and increases the pressure and helps to facilitate the drug into the walls of the vessel. And you monitor that by having, I'll tell you what, this thing is not working. I thought I'd ask them to change that. You monitor that by the pressure sensor, and you maintain a specific amount of pressure throughout the whole procedure. And that's actually how this works. And I can skip several of these slides by doing that because I have. And if you, this is kind of a busy slide, but if you look, it's got checks all the way down under that particular OPC catheter that the others do not. Now, what we did is we did some preclinical studies using rabbits, all right? And what we wanted to do is we wanted to see what's the optimal concentration of drug that we can use, what's the optimal pressures we can use, what's the dwell time, which is actually one of the most important things is the amount of dwell time, because we want to decrease the length of these procedures. And, oh, thank you. And so this is in a rabbit model here using electron microscopy, and we fluoresce some paclitaxel. Paclitaxel is a drug of choice right now, and so we have lots of data on paclitaxel, and we want to compare it. So we're going to compare this to other balloons here after a while. But as you can see, we actually got all the way into the intima, went from intima, media, and almost out to the adventitian rabbits, okay? And it was uniformly placed. This is just another model. We found out that if the pressure was 2 atmospheres for 2 minutes, we continued to get uniform uptake of the drug in the walls of these animals. And this is just another. And this is an important slide. This is looking at all the different concentrations. And what we found that the concentration between 0.1 and 1 is actually the optimal concentration going from 100%. And this is out as far as 8 days out here that we still have drug present in the walls. This is looking at all the different, looking at the different drug balloons. We're looking at the OPC catheter, and we're also looking at the OPC catheter with and without excipient, okay? These are your 2 drug balloons up here. They're actually both. And what we found between 1 and 0.1, this is the optimal range for drug concentration and also delivering the wall to get a 90 to 99% inhibition of the arterial smooth muscle cells. As you can see, and the purple line is actually the OPC catheter, and we found that with the mixture, with the excipients that we use, that this actually falls right nicely in the range. These are your drug-coated balloons. You can see they're tapering down, and this is without excipients, and this is the older balloon that first came out. This here is we're looking straight a head-to-head comparison to drug-eluting balloon. And you can see that there's almost no growth of smooth muscle cells in either one of them, so it makes it, probably the OPC catheter has been shown at least to be equivalent to the drug-coated balloon. This again is electron microscopy of looking at smooth muscle cells of the OPC catheter, and this is at 28 days after sacrificing the animals. We looked at the smooth cell growth, and this is compared to drug-coated balloon, and there's actually essentially no difference, as you can see here versus here, of smooth cell growth. We actually are now conducting the first-in-man use of this catheter. And the first-in-man use is the copper A and copper B trial above and below the knee. The very first catheter we used at Springhill a few weeks ago, in which we delivered drug successfully. And this is actually what it looks like in the cath lab with your occlusion balloons. The middle balloon is not blown up at this time to give us a little bit more better effect, you know, kind of like a nice effect for y'all. Y'all can actually see where the drug is being eluted out into here. And it's the copper A and copper B trial. And it's an ongoing trial right now. It's a multi-center trial also. So we want to have the ability to deliver it circumferentially. You want full inhibition. Our catheter is not restricted by a single agent. We can actually mix agents if we need to. And also be able to flush the chamber. And it also, clearly, the most important thing is in the long run, you'll be able to decrease costs because the cost of paclitaxel is so low, and also being delivered in multiple areas using a single catheter. Thank you.